Our next talk is preparing the workforce for collaborative interprofessional practice and optimizing the way members of the cancer care force spend their time. For this, we're lucky to have John Cox here, who I've known for many, many years. He's been a practicing oncologist for many years. He is now the medical director of the cancer services for the Parkland Health System. But many of you will also know him as the editor-in-chief of the Journal of Oncology Practice, which he was between 2009 and I think just last month, maybe, when he turned those reins over to one of our colleagues. So John has this very interesting, from my point of view, this very interesting position of knowing what it's like to be on the ground and practice and lead a practice. So he's both providing care, leading a practice, but also has this view of our profession from having reviewed probably 10,000 manuscripts that were submitted to JOP over the years, many of which dealt with these issues. So he's got quite a unique perspective. And John, thank you very much for being here.
Well, thank you for that, Larry. I must admit being quite humbled to be on this panel with the caliber of speakers, and what I heard this morning was quite inspirational. I fear that I'm going to duplicate a little bit of what you've already heard, but maybe that's not bad, because I think my first conclusion is, and I think it's obvious to everybody here, if you're going to affect the workforce with basically not changing the number of physicians in the space to any huge degree, we've got to work completely differently. And I see that there are kernels of, in everything you've heard about this morning, that can point the way. And I think it comes to some of the things you heard from Dr. Carlson. It's teams and teaming in cancer care. So I'm going to focus on that and then put some ad hoc comments of things that I think affect this whole conversation about teams. All of us, if you ask any oncologist, regardless of stripe, of specialty or whatever, about the healthcare team they participate in, they'll describe a team. All of us believe we are parts of teams. And yet, I would argue that for most of us, and I would say most in the far high percentages, have never participated in a high-performing team like you heard Bob describe. Most clinicians have not participated in such teams. And our salvation, both for the practice of what we do as well as our own well-being, I think is really tied into learning these principles and refashioning what we do within team care. Cancer care is transactional currently. It is the silos, I think, have ever gotten more high and more thick. We do participate in groups. Bob described this, the group versus team a bit. Each member of the group knows their task, but more and more we find ourselves, I think, more myopically focused on what that task is. What leads from that are a lot of misconceptions and gaps in care. And to be honest, the only persons that really carry information between institution and between care providers is the patient or their caregiver. And often that comes with gaps. So my talk comes from sitting in my editor's chair. Maybe one of the most satisfying projects I dealt with was one Suanna introduced to you earlier, and that was this combination of ASCO and NCI focusing on team care. What do teams mean? This led to a call for proposals and for folks to come together that were interested in redefining how they deliver care in teams. And ultimately, there were 23 teams that filed a proposal. ASCO brought these folks together, and there was a team scientist assigned to every writing team. The idea was each of these teams would tackle a problem, use team principles, and I realize I'm going to go off into the other world here, but there exists a deep literature about teamwork, but it doesn't exist largely in medicine. As Bob was saying, it exists in manufacturing, in military science, in the business world. And yet many of these principles have great knowledge to impart on how we should work. So a team scientist was embedded with the team. Also patients or patient advocates were embedded with each team. And then they took off. We met. I actually did not participate as editor of this project. Mike Costi and the workforce group from ASCO, I was in one of those teams. And it was a fascinating experience. We met. The teams then presented their projects and principles in which there was a group critique. And then what came out of that was a team's issue. And actually, this has been a series of papers that broaches more than one issue in the Journal of Oncology Practice. But in November of 2016, most of these papers were presented. And there were several that both reviewed the literature, editorials by those team scientists, and multiple of these papers presented and illustrated how you could use team science in the clinical care of oncology delivery. I won't go through this. Bob touched on this. I'd highlight the last paragraph is we need to move from groups to teams. And as he highlighted, those characteristics of high-functioning teams is distinguishing a vision and goals, establishing roles. So everybody knows what their focus is, but they also know what everybody else is doing. And manage these interdependent work groups, becoming truly a high-functioning team. And these, again, are 4 basic characteristics of these real teams or high-functioning teams. And this would be interesting for you to go back to you all believe, or physicians believe they're members of their team. Ask them to write down a list who else is on their team. And then go to any of those individuals and ask them to define who their team was. I would dare say there are very few of us that would have congruent lists. They're committed to achieving team level objectives, and this needs measurement, as Tony was emphasizing. They work interdependently to achieve these objectives. They know their inputs and they know their outputs, and they know what happens to those on both ends of that equation. And then most definitively, what does not happen in oncology is we don't sit with our teams and engage in any kind of reflection or thought or intent about what we do. Again, I learned there's a longer list than this about these team principles that have literatures about how teams work, how they have shared identity, team level objectives make sense. But I love this term, a shared mental model, that a team really grasps about everything they're doing. And that allows, for the example given earlier, when maybe the clerk at the desk sees something happening, they don't just check in the next patient. They accept their work and ensure that that patient is tied in. It takes something with intent to create that shared mental model. Tony highlighted, and I think these issues on the right are extremely important that we don't exhibit in our workplaces, is a psychologically safe area to speak to power. And physicians often are considered the irreproachable or the administrator or the boss. You've got to remove some of those barriers. It means effective teams have to have trust in one another. And I love the idea that these high-functioning teams, we all know that collectively you make better decisions. Teams do think, and they practice, something, again, that comes from that reflection. So my last several slides is thinking about the project that Larry has been tasked with, of rethinking workforce issues. I think the biggest thing I take away from what I've already heard today is we have to work differently, and I think it really comes down to creating a different team model of how we approach patients, families, and it includes patients and families and includes a defined role in the clinic. There is a bit of zen to this. Whenever I listen or read Tony, I don't have any idea of his greater worldview of things, but I'm always taken back. Mindfulness, I think, can occur within a team, and we have to share in that. I think we have to shift our attitudes, self-reflection, particularly for physicians, and really realize how interdependent we are if we're going to provide good quality care. All this has to, if you're going to remodel the team in the clinic, you've got to have support from governance. You need team leadership, but you also, as Bob was saying, need high-level leadership and commitment to provide space and time to make this happen. And then one thing for my editor's chair I saw more and more is as the journal grew, and now you see these papers in lots of journals, including the highest impact journals in our professions, is more focus on studying how we deliver care delivery focus. And that's the mission of the JLP, and I really think there's a niche for really digging in to asking how we deliver these remarkable science that are at our fingertips. Lastly, on this slide, I'd like to focus on the way to bust up some of those silos has to be to change how we're paid. So the opportunity of alternative payment models, Ron Klein was in the room, I don't see him where he went, but about the oncology care model, we need to get on the road of where we get rid of fee-for-service, because fee-for-service, RVU-based contracts, this all affects how our teams are going to function. I am troubled in my day-to-day life with and it impacts the idea of how you put a team together, is this word we love to use, top of license. Nobody is practicing to the top of license. And a lot of it comes down to getting that data in the computer and the like. But a lot of it is that we're not reflective on team and figuring out what we're doing. So I don't want to blame just EHRs or just payments. I think we could do better under the current system if we could just build more reflection into it. I do struggle also with the butting into compliance. The example of the RN earlier really reads true to me. In fact, in ambulatory oncology, I worry about nursing because it has become such a clerically oriented task. And at least in private practice where I left, that was being realized by cutting down the number of nurses in the practice and realizing that all the tasks your RN is doing could be done by an MA. And where the compliance, and I run into the same thing in an institution because of JCO and compliance, and people can't do this, that, or the other. So it's going to take, from a policy point of view, I think diving into to what focuses us in, or holds us into the roles that we're in. APPs, I think, are clearly a stalwart of what comes to our future. And Suanna gave you the data on this. We published this paper from their group in September that really looks at how APPs are working in our practice. I think as you see our oncology teams expand, they're going to be rich with APPs as truly extending quality oncology care. My last two slides is I can't speak to any group without saying there is an issue that is sucking the soul from me and my colleagues, and this is growing. I practice in Texas, a non-expanded state. 4.5 million people in Texas without health insurance. 600,000+ of those uninsured live in my county, Dallas County, one county. And you spend more and more time dealing with the constraints of decision-making that is made externally simply because these folks don't have a ticket to the party. These financial issues invade the clinic. They invade the institution. No way Parkland's going to be able to do CAR-T. And immunotherapies, these new immunotherapies are going to challenge us just by the cost of drugs alone. I don't know, without those kinds of access issues, all I can say is the workforce is very dispirited when you deal with that day in and day out. So my call to action, I realize I'm very short on time, but is reframing our care teams to be high-functioning teams. This requires a different kind of education. Old guy like me, I'm amazed, and maybe now that I can reflect on this, I can say this is really cool stuff, but carrying this to the clinics, and you're going to have to retrain basically how we deal with one another in many ways. You need governance and support. Access to care will demand all of us working differently. And then I, again, emphasize the issues of financial restraints to care. We shouldn't be Orwellian where some of us are more meaningful than others in our society. So I'll shut up.